And we have all made adjustments. Are there, so maybe this talk will let everyone think about any sort of adjustments that they wanted to make having to do with mental health. All right, this is, like I said, around the world. So let's start in China where COVID started. I actually took this photo here. I went to China and I actually went to 7 different Asian countries right before the pandemic, the year before. So not too close to the pandemic, but pretty close. So I thought it was a trip of a lifetime, and I had no idea how much of a trip of a lifetime, because all of a sudden everything has changed. So in the beginning, China was reporting pretty low rates of mental health problems. But look at this quote here. This was written in an article. So in the beginning of the pandemic, the literature really focused on what everybody was predicting. And so this person here predicted that the lockdown in China was so good that it prevented spread of new cases to both the Chinese mainland and the rest of the world. So I'm glad I'm not the one that put that in writing for posterity. At that time, the rates in China in the beginning of the pandemic, pre-pandemic is the 14%. And then so they estimate, at least this one paper estimated it's increased, doubled at least. And even more for ideation of either self-harm or suicide. And Italy, of course, everyone remembers Italy in the beginning and how overwhelmed their healthcare system was. So this author wrote an article about what had been happening in February through May. The author really emphasized that mental health was very important to them in terms of them being a healthcare system as a whole. And they stated that resources were not diverted away from mental health care. And they felt they really have a reduction of stigma against mental health providers, patients, that sort of thing. But then they listed all the things that they had changed due to the pandemic. Physicians and nurses diverted to other wards, like away from psychiatric wards onto medical wards. Consultations limited to the most severe cases, again, psychiatric consultations. And then partial hospitalization programs. That's when you go to a day program and then you go home at night. And the psychiatric inpatient were temporarily closed. And this is a very common story around the world. And even here in El Paso, probably a lot of y'all heard that the El Paso Psychiatric Center closed their child and adolescent ward and turned it into the COVID isolation ward. And so we were that was really hard for us, because that's where we train all of our fellows in child and adolescent psychiatry. That would be like closing Children's Hospital for the pediatric residency. So it's been very hard on us. But this month, we started at Rio Vista. So our fellows are now going to Rio Vista, but it's been hard because they only take one fellow at a time. Hopefully the fellow that's there will do such a great job, they'll decide they can take 2, because they have to get this experience before they graduate, and we're running out of time. Because of course our program is only 2 years long, the fellowship. In Italy, they also did some survey research. Dr. Handel wants to come in, there we go. In Italy, they also did some survey research, and these were the things that people were reporting on survey. Now, when you do survey research, of course, you're either getting the perspective, it's mostly adults, but there's other studies that they did where they captured more of the pediatric population. So in Italy, and you'll see these numbers are very similar all around the world, 42% reduction in inpatient admissions. These are psychiatric admissions, but really everybody knows that even medical complaints, visits, ER visits for medical complaints also is the same thing, a huge drop, especially at the beginning. Now, this is an interesting finding that is showing to be true here in the United States too. Self-harm and suicide attempts, while they also were decreased in terms of visits for those things, they were decreased, but they are a larger percentage of visits than before the pandemic. So there's a lot of literature that says people are reducing their help-seeking behaviors during the pandemic, but they're reducing their medical help-seeking behavior
more than their psychiatric. So that was an unexpected finding, I think. Maybe someone else expected it, I don't know. Depression was a larger percentage now than before the pandemic. Psychosis remained the same. This is a finding that people have shown all over the world. Psychosis, you're either psychotic or you're not psychotic. And I think that this is such a severe symptom and it's so hard to function. These people are still seeking help. And a large percentage of them are probably involuntary admissions as well for the adults. And then in Italy, they noticed an increase in the admissions for OCD. So a lot of people were predicting that OCD was really going to flare up. All the patients that were susceptible to that or had active symptoms in the past, their symptoms have really increased. And they found it significant, but it was significant. It was, numerically significant. It wasn't a huge amount. And we're seeing some of that, but here in El Paso, I'm sure everybody probably has one or two patients, but for the most part, if your patient was stable, they remain stable with the OCD symptoms. But, we never know until we do a lot of research after everything's over. So Paris, let's go to Paris. Okay. There was a study done in the first 4 weeks and see how this same thing, 45% fewer visits. The numbers are very similar from country to country. All diagnoses visits were reduced, medical and psychiatric, and all the psychiatric diagnoses. No matter what your diagnosis was, the people with that diagnosis were going to the hospital, or this one was emergency rooms less, much less. There was an increased proportion of involuntary versus voluntary commitments. And then this is, of course, mostly young adults are the ones that end up with an involuntary commitment. And that makes sense that would be a larger proportion because those are the ones with the most serious illness. And psychotic disorder admissions decreased the least. And this author thought it was the fear, which I'm sure is right. People were afraid and they really, really were staying away from all hospitals. This one is specifically with children and adolescents. They measured psychiatric admissions in this age group. March to May also decreased significantly, 46% compared to the previous years at the same time. Now, there's a lot of good research, and look at this N, 69,000. The universities all over the world have been doing amazing research in terms of their numbers. They have, how universities, just like Texas Tech, somebody has all of our email addresses. And so people in the beginning, of course, are just glued to their computers wanting to find out more. So I think that's how they were able to get such a wonderful number of patients, these are not patients, these are just regular students, college students to fill out this survey, 69,000. And here's what they reported. 11.4% of them reported suicidal ideation, 22.4% of them severe distress. And you'll see in a lot of the research that I'll go to around, in the United States and Texas, this is a very common finding that your highest reported area is going to be a distress category. So these are people who it includes all the people who actually meet criteria for a psychiatric disorder, but they're just reporting themselves subjectively as being in severe distress. 16.1% were likely to have moderate to severe depression, and then 27.5% anxiety. So actually the anxiety score is a little bit higher than the severe distress. And you'll see these two are the highest in most places. Now, this was a funny study. Also university students, increased anxiety reported by 100%. I don't know that I've ever seen a study that reported anything 100%. So you got to take this one with a grain of salt, but I had included it just because it had a couple interesting things. One, 100% finding, which I don't know, maybe it was 99. I don't know. But anyway, they reported 100%. They reported 12.43% depression. So let's see, in French, it was 16.1. So in the same realm. Females twice as likely to develop depression. This is a finding all over the world as well. in normal times, not after puberty, they're twice as likely to develop depression. And this is a finding that many other countries have found. If you have had if a person has had a previous suicide attempt, they are much more likely to be reporting symptoms, psychiatric symptoms. Now, this study looked at all of these psychiatric symptoms, and psychiatric history, but then they had a section about conspiracy theories. I thought that was so interesting. And I couldn't believe it. They said that the female students were the ones that were more likely to believe the conspiracy theories. So I don't know about that. Maybe I'll just discount it because they got this 100% up here. But they found that so what they did is they took 12 conspiracy theories, and then you checked if you believed it or you didn't believe it. And the women were more likely to believe it. And if you're a liberal arts major, you are more likely than the science and engineering students. So I don't know. I had to include that because it was just such a funny study with two completely different things. But really, they did tie it together by saying people are believing things that are very extreme. And so maybe that is leading into fear, which leads to people to have psychiatric symptoms, but then at the same time, they're staying home. The UK also has had a horrible time with COVID. This study was done at Cambridge. No 100% findings here. This was in March. If I don't have a date on here, we all know that's 2020, right? March through August 2020. Significant decreases in help-seeking behaviors, decreased admissions, referrals, outpatient appointments. These are all talking about mental health programs. Their early psychosis program, though, remained the same. And the eating disorder admissions remain the same. Most of the studies I saw did not mention eating disorders, but that one really makes sense because you also get so many medical complications with eating disorders. And then there was they kind of added a whole different section of research onto the end and looked at, this could have been a whole paper in itself probably. Those with serious mental illness, and when that term is a specific term used in psychiatry or the field of mental health to mean people with bipolar disorder that is severe, schizophrenia, and schizoaffective disorder. They are dying of COVID at a higher rate, which is very, very sad. But at the same time, this is a finding that we really only realized probably in the last 10 years or so, and that if you have a serious mental illness, your life is usually 20 years shorter. So we don't know what to do about it. It's extreme, it's terrible, but it's one reason that I'm so glad you guys are here with us tonight. Portugal, same findings. You can see decreased by half their emergency visits. In Portugal, women and children had larger decreases. Mood disorders had the largest decrease in presenting to the emergency room. And that one is not consistent. Psychotic disorders were consistent amongst all the different countries. Mood disorders in some countries they were not presenting, and some they were presenting. So that just really depends. And this was a funny one. ADHD is the second most likely to have, or second least amount of decrease. And I'm like, who gets admitted or goes to the emergency room for ADHD? But maybe it was just that it was a secondary diagnosis and they have a public health system. So perhaps, or a socialized medicine type system. So maybe they just had more accurate records. And so they always had ADHD on there if that was any time in the person's lifetime. But I don't know that I've ever seen a presentation to an emergency room for ADHD alone, but I don't know. And they also reported that they had closed partial hospitalization programs, closing their outpatient clinics, and just like the rest of the world, they reverted to telephone visits in the very beginning while people were setting up video. New Zealand, it's amazing to read about New Zealand during the pandemic. And they claim that at the time of this article, I forgot, I should have put what month it was, but that it was written, but they only had 1,400 cases
in the whole country. So they were able to do a better lockdown. It's a very small country. It's very isolated. It's an island. It's far from most of the world. But they also report, they're worried about their mental health because it was a very extreme lockdown. But again, the anxiety rates are lower than some reported in the European countries. But what is interesting is that the younger you are, the higher reported symptoms. So when they did the screening for anxiety, or the survey for anxiety in this age group, 18 to 30, it was twice as high than in the overall population. And then look at this, 75 and older only had a 5% rate of anxiety. This is amazing. It makes you want to be 75, right? And there's not many things that make you want to be 75, but you'll have less anxiety, hopefully. But this is very low, and it's just such an extreme difference from this young age group to the older age group. They also did a well-being survey, and 38.2% of their population reported low well-being. And this is a survey that they have used in the past, just surveying their population to see how people are doing. And their baseline low well-being, I thought, was kind of high, 25%. But you can see it's high, much higher during COVID, 38.2. This one went all the way down to 15-year-olds. 50% of the 15 to 24-year-olds reported low well-being, whereas only 19% of this oldest age group for this survey, 65 to 74. So you can see it's very, and this is, you'll see later that US is having similar findings. Family harm. This is what the term that we usually use, family violence. In New Zealand, they call it family harm. Their rate is 3 to 4 times higher than it was in 2018 and 2019. So that's sad. And I know as pediatricians, this is something I've heard about y'all worrying about a lot, and everybody in child mental health professions, we've been worrying about that, and we don't really know what to do about it because, of course, the CPS workers are not going into homes as much, and they're not getting as many reports because the kids aren't going to school. And the vast majority of reports come through the school because they see those kids every day and they really notice when something is wrong. So that's going to be our challenge in the future. Here we are. We're back to the good US of A. Okay, let's see. Emergency department visits under age 18. In March through April, 42% decrease in visits in all age groups. January. Now, this is a finding that has been published all over the world too. In January to March, there were elevated rates of psychiatric visits to ERs in many, many countries. And we don't really know why that is, but it's a finding that I've noticed in several different papers that have been published. And of course, March 15th through October, that's what similar, like half. But the larger proportions of visits were mental health related. So, the media keeps reporting that there's more mental health visits to emergency rooms and doctors' offices than there ever were before. And it's actually not true. The proportion is higher. So people are probably, they're scared, they're staying home, but they're staying home more if they have a medical concern than if they have a psychiatric concern. And I mean, that's a complicated issue. I don't know why exactly that is, but I guess you can live through a lot. Okay, this is the same data, but in a graph. I thought this was an awesome graph to show you the point I was trying to make. Okay, the top graph is the dotted line, and you'll see in all these studies, it's so funny, the dotted line is always 2020, and the thick line is always, or the straight line, I don't know, non-dotted line is always the year before, pre-pandemic. So you can see that in the beginning of the year, this is the US, there was quite a bit of elevated mental health related emergency department visits. Now here you see at the very beginning of the year, see how low it is on this side? Christmas, kids love Christmas. There's no school, there's toys. I don't know, they love it. And then around here is summertime and a little bit happier too. But of course, the curve was completely different, except for Christmas, because that was before COVID, for 2020. It shoots straight down. This is around mid-March when the national emergency was declared. And then, but then you can see after a certain amount of weeks, I don't know, let's see, about 10 weeks, it goes back to normal levels. And this is the summer months, and you start getting in toward the fall. School's starting again, but it's not quite as many as previous. And these numbers on the bottom, I should have said that first, this is a week number. So the first week of January, the second week of January, and so on, all through the year. But this was only done until October. And I'm sure as pediatricians and pediatric health providers, you notice that September, they've been in school for a little while. They start to get stressed. They start, feeling like their teachers hate them, or they start getting bullied. This is a stressful time for kids. In child psychiatry, we always see a peak right here. So this is the proportions, the second graph. So proportion of mental health related visits to medical visits. And these are the 2 years. So there are fewer visits overall than in previous years, but especially if you just take from the pandemic on, but the proportion, as soon as COVID starts, there's a higher proportion of mental health related visits. So it's interesting. These are the sort of psychiatric symptoms that are reported. This was from the CDC, and it was published in the CDC. I've forgotten who it was done by, but I think it says on the next page. And I have a lot of references at the end. If anybody wants, this is like a brief overview. I know you guys don't want to dig in and read all this stuff. So at the end, I have I don't even know how many references, and I'll send you all this PowerPoint so you can link to the references. This was done, I think, in June. So it was a big survey. No children in this because it was survey research. This was like a voluntary survey. They sent numbers out or emails out over the entire United States. So 40% of Americans were reporting a psychiatric symptoms. And this is, like I said, in June. But again, just like I was discussing before, the youngest age groups are having the highest amount of symptoms. 75% of them report a psychiatric symptom. The 25 through 44 age group, I'm not in that one anymore. But anyway, 51%. And so if you're older than that, you probably weren't, you are weathering this emotionally and mentally better than the younger folks. If you're Hispanic, you report there are higher findings in the Hispanic population that answered this survey. And this is not a finding that was common in literature, in a lot of literature that I've looked at before the pandemic. So that is something really concerning, of course, because that's our people here in El Paso. The less education you have, the more likely you are to report symptoms. And essential workers. And I was surprised by this, essential workers. So 54% of essential workers reporting psychiatric symptoms compared to 40% for the overall population, or the overall population that answered the survey. To me, I feel like my essential job is what has saved my sanity through all of this. I got to get out of the house. I got to go to work every day. I get to do what I'm good at. That sort of thing. I really feel like it saved my sanity. But essential workers are having more symptoms than the average person. If you had prior anxiety symptoms, 72% of these people had psychiatric symptoms during the pandemic. If you had prior depression, 68%. And look at this PTSD, 88% of them had. And there's a little bit of research on past pandemics that says something similar to this, that there are a lot of, and up to 30% of kids after a quarantine type situation will report PTSD symptoms. So these are going to be our vulnerable people. are kids, but then people that have had prior problems with mental health, prior mental health problems. Oh, I took this picture here. That's everyone knows where this is, right? Ranger Peak. I hiked to the top of this mountain. It was a nice day with some clouds. Dr. Saloom's hiked up there too, right? I bet Raul has. No, I don't know. He likes to go to the gym, not the nature hikes. Okay, nature hikes. That is another thing that has saved my sanity.
I do hiking, and I fell twice.
Yeah. All right. No, so hiking has definitely saved my sanity also. So this is the same survey, but it's looking at the suicidal ideation statistics. So 10% were reporting SI, so that's lower than some of the other countries. In the 18 to 24, though, look how much higher, 25%. The risk for suicidal ideation is higher if you're Hispanic and unpaid caregiver. Now, I believe that they were not talking about stay-at-home mothers or stay-at-home parents, mothers, fathers. I think they were talking about if you're taking care of your parents or your grandparents or something like this and you're unpaid. This was a population that's been very, very affected by this pandemic. Essential workers, again, men were having more SI than women, and this actually is not typical. In a regular year, women have more suicidal ideation. Of course, men are much, much, much more likely to actually complete a suicide. And then employed more than unemployed. So I don't know. These were some interesting stuff. And here's a chart that, so this was April and May. Sorry, I said before it was June. It's April and May. This chart, I don't know. I know if some of you guys that are looking on with the phone, it might be hard to look at, but you can just see the Hispanic Latino population. And it's not a huge study. It's 1,000 people answered. There were 118 in the Hispanic Latino group. And I don't know where they were, if they were in our part of the country or another part. But look, I put them in red because they were just so much higher than all of the other groups. So, and it's usually the white population that has the highest in these sort of suicide categories, but not during this pandemic. So the substance use statistics. Now, this is the same survey, April and May, 1,000 people. And unpaid caregivers were the ones that were most likely to either start using substances or increase their substance use. And again, the young people and our Hispanic population. So that one, the rates were not as significant. So overall, the 6.3 was for all the people. And that was the average of all the people that completed the survey. Only 6.3% of them either increased or started. And I would guess that people are under-reporting substance use here. I would guess that the average person, there's a lot of the average people that are, increasing their substance use during this stressful time. But I don't know, supposedly only 6.3. So here we're getting to actual suicides. There's very, very little research on actual suicides, and there's many factors. So, usually the suicide statistics, they spend a lot of time tallying them up, making sure that they're accurate. They collect, of course, the CDC collects for the entire country, but then it has to start at the local. So like El Paso will report to the state will report to the CDC, and that takes a long time to get all those statistics. And then El Paso, or every medical examiner's office in the entire world has been completely overwhelmed. So the total statistics for suicides during the pandemic, it'll probably take another year before we have large numbers that represent the entire United States or even the entire state of Texas. But in Japan, there was a small study that looked at under age 20 suicides they were predicting that there would be an increase during the school closure. The school closure, of course, they're talking about the pandemic. Because of the pandemic, they closed their schools for a period of time. But that's not what they found. That's not what they found. And I didn't put a slide in here because it was only a partial statistics, but in El Paso, from the statistics I have so far from the medical examiner's office are from up until July 2020. And for adults, we only had 40% of the number of suicides that we usually have in previous years. So instead of being a lot more, there's actually a lot less, at least in the beginning of the pandemic. And that's what this study showed. Now, El Paso has very, very few child suicides. In 2019, there were 2, and in 2020, there were 2 up to July. Like in that same period of, I was looking at, of course, March to July, there were only 2 suicides, both in 2019 and 2020. Now the reasons that the people, I mean, these are all theories. These are the authors thinking, but they did talk to some of these kids, and they said they were worrying less about academics. There wasn't as much bullying because they weren't with their peers all the time, and they didn't have to worry about their school relationships. They had more family time, and the reason this study is not directly comparable to the United States is because the suicide rate in Japan has been stable for 20 years, whereas the suicide rate in the United States has been increasing in the last 20 years. Another very sad story. So this is their suicide rates in under age 20 children, and these are the months of the year on the bottom. The dotted line, 2020, the light gray, 2019, and the dark gray, 2018. So yeah, there's not only are there not increased, but it's actually had decreased amount of suicides. Houston, Texas. Okay, so this is a study done at I don't know. The authors are from Baylor. I don't know if it was probably one of their hospitals too that where the ERs were, but that's here in our state, in our own state. So during ER visits from March to July, they screened for suicidal thoughts, and they found that there were higher rates of suicidal ideation than previous years in March and July. But if you take March and July, but if you take March to July, it was very similar to the previous year. So I know people are predicting doom and gloom, but it hasn't. It turns out that people are much, much more. And this one was in children, kids especially, but adults too, because you saw those really low rates of symptoms for adults. We're just much more resilient than, I guess maybe we were worried that people would crumble and be committing suicide more because of this pandemic. And it's just, it hasn't happened yet. Now, of course, people are wondering, okay, well, let's say we only had 40% of the amount of suicides this year. Does that mean we're going to have, a huge increase next year? I don't know. Something like this has never happened before, that we were able to survey electronically about suicide and that sort of thing. So we will learn a lot because all of this is new. Pandemics, of course, throughout history, but how we measure what's going on during them is completely different. And March and July so March, of course, that's when the national emergency was and everybody started having lockdowns. And then July was a time when Houston had a large number of cases, and so they went back into more of a lockdown situation. And there's a review article on COVID-19, but also included some past statistics from other respiratory epidemics, and none of them showed a clear positive correlation between a pandemic and more suicides. So it always remains to be seen. Okay, so here we're getting to the clinical part. So I've forgotten what agency put this out. This is the COVID-19 Youth Suicide Risk Screening Pathway. This thing gives me a headache. It's very complicated. You can't read it. I have a big
screen on my computer and I cannot read it. I can, maybe if I
This Dr. Martens, this can give anxiety. It's already
I know.
Yeah,
I know. So
phobia.
I don't want to show you that. I want to show you
Yeah.
this. Simple is best. So first of all, if you, when you're screening for suicide, use what you already use in your clinic. The ASQ is very simple and straightforward, and they have a toolkit you can download. Probably most of you already use something, and probably, oh, I think Dr. Covarrubias is trying to talk, but he's on mute. Did you try to say something? No?
I would just agree with you that I'm using the PHQ-9 and it's kind of helpful.
Yeah, so the PHQ-9, most of the, anything that had to do with depression, and almost all these studies all over the world is using the PHQ-9. So it's a good thing that it is popular all over the world, because then we'll really be able to compare studies to each other, because it'll be at least the same questions. And then the Columbia suicide screening, this is from Columbia University. And this is for a kid where either the ASQ or the PHQ-9 are elevated, or they said yes to the suicidal ideation questions. Then you can give them this Columbia suicide screening. And this is owned by Columbia, but all you have to do is write to them on their website and they say, yes, you can use it. So they say yes to all clinicians. And they even say yes for training programs and everything. They have a, I think it's called like the Lighthouse, or they have some big grant they got to try and train people all over. So you not only can you just print it off the internet, but you can also, there's little online trainings, and and I think it's a little bit weird, but they have one that's even, you can use in, supposedly in the preschool group, which, you know, you don't even really know what death is, but you all have probably experienced where a very young kid says something that sounds suicidal when they're really mad or they're really upset, and really they probably don't know what they're talking about. They don't mean they're going to kill themselves, but you never know. So anyway, this is a way to assess the risk. Are they thinking about it, but they're willing to let you help them? Or is it just too risky and they need to go to the hospital? And this is something kind of concrete. You can show the parents too, because, you know, there's so many parents we have. I mean, who wants their kid to go to a psychiatric hospital? Nobody. And so sometimes we do need to do a little talking, especially when you don't know the patient. So a lot of times we'll see patients in the ER, because we consult with Children's Hospital, and the parents, they've never seen us. They don't know who we are. They're scared. Their kid is having all these symptoms, and they don't want to take our recommendation. So sometimes you can use this. It might be one more piece of evidence to help a parent decide on the next level of care. So really, when someone's suicidal, we recommend doing one of these and then decide on the level of care. We don't want this too complicated. So the AAP has a position paper and a toolkit on mental health. So if anyone is interested in that, they have a lot of good resources. A lot of the agencies do. This is a paper that was written together with the Child Psychiatry Academy and the AAP, talking about how it may be better in many instances for a child to be treated where they're used to being, in terms of in your office, instead of having to go to a brand new doctor, that there's more stigma around having to visit a psychiatrist and that sort of thing. So I always, whenever I present to a group of professionals, I always look to their own agency, their own occupational organization, professional organization, and see what their stance is. And all the family practice, the PNPs, FNPs, they all have something similar to what this slide is, and encouraging their members to take care of the mental health needs of their patients, and that they're not practicing out of their scope, kind of reassuring them that if you want to, you can branch out into this. And they also have a large amount of tools. So never fear, health is here. So the state of Texas has taken kind of the position that the AAP has,
And also, of course, in Texas and really all over the world, but there is a shortage of child psychiatrists. And so they have put a lot of money into supporting you all as primary care providers that see children, to providing the best care possible, because they know that not all of our kids can see a psychiatrist when they need to. So we are part of an organization called the Texas Child Mental Health Care Consortium, which was created by the 2019 Texas legislature. And so, it's great because many of the health-related institutions in the state of Texas are huge. They have tons of bureaucracy. They have a lot of employees, and it's just very, very big and complicated. So they decided to make it simple, and what they did was they asked all the medical schools in Texas to join this consortium. And there's 2 people from each medical school in Texas that are part of the executive committee, as well as a representative from the state hospital system, the HHS, Health and Human Services. And then they gave us $100 million to come up with many new programs having to do with children's mental health. So the CPAN is one of the main ones, and it provides education on mental health. It provides curbside consults, and we can also help with referrals. So this is a Nelson Mandela. That one didn't come out very well, and it's kind of fuzzy, but anyway, may your choices reflect your hopes, not your fears. And we all hope that these children will do well and they'll get better and we can help them. And so we want to help you do that. So we focus on anxiety, depression, and ADHD. And I'll tell you, pretty much nobody needs help from us with ADHD until like 3 or 4 medications has failed. And then you're asking us about that. It's these other 2 that we get more questions on. And really, I get probably a lot of questions too, when kids' behavior is just become completely, because of an emotional problem, it's become completely unacceptable in their environment. They're disrupting the classroom if they're in school. Or making their family miserable by hitting and breaking stuff and that sort of thing. That's the kid that Dr. Salum called me about today. Let's see. So we can help you with screening, what screening instruments to use for certain disorders. We focus on screening, diagnosis, first-line treatments, and the referrals if needed. We're not asking you all to keep patients in your clinic if it's going to be detrimental to the patient. If someone really needs to find a child psychiatrist, we'll tell you who's taking patients and who will see your patient that has insurance, that will take your patient's insurance and that sort of thing. We'll try to get them help as soon as possible. And these talks, like this talk I'm giving today, we have a series, and oh my gosh, people all over El Paso and all over Texas have been logging on. So we're getting to know a lot about different agencies. Here is our region. So we're not just El Paso County, we cover all these counties. And the only county that has any child psychiatrist at all, right here in El Paso. So see, you guys are lucky. You can actually refer to somebody. These other ones, they can refer to the local LMHA. Like here we have Emergence Health Network, EHN, that kind of county mental health. And they have some telemedicine where they can see psychiatrists, but it's very limited. So compared to all these other counties, y'all are doing that. Raul, did someone ask a question or something? Is that what you're?
No, I just wanted to mention something for the pediatricians here, or actually for everyone. Also, if you have colleagues that you know that would benefit from this program or from this network in any of those counties or throughout the entire state of Texas, you can refer them to CPAN. Like Dr. Martin mentioned, we're here to support every single county in the state of Texas. But for TTU HSC El Paso, this is the area that we service. So if you have someone that you have in mind as to they can benefit from CPAN, let us know.
Yes, please. Yeah, this is everybody who has any kind of license in the state of Texas.
Can I mention something, Dr. Martin?
Mhm.
I appreciate this program, CPAN, because actually this decreases our anxiety as a physician. Because we have some, like the child I called you right now, he's hitting the wall, hitting the computer, aggressive, hitting his sister. Another one, suicidal attempt, suicidal idea. Actually, you take this load and anxiety from our part, and your response very fast is very appreciated because you make it easy for us. Because when this patient come to us, we have more anxiety than the patient. But right now, since we know that we have this resource, we become more relaxed, honestly. And we're more relaxed, the family will be more relaxed.
Good.
Thank you.
Good.
Appreciate you. We appreciate this business.
And you know, our outcome measures are, and you guys will start to get them by email if you could fill out the survey. We did a really short survey, and really what we told the Texas legislature that we would accomplish was helping you all to feel more comfortable in treating mental health problems. So treating kids with mental health problems. So that's our main goal is to reduce your anxiety. Dr. Handel asked a question. What is the position of the APA about return to school? You know what? I don't know. I'm going to look it up now. I'm going to find out. I think a lot of all the psychiatrists I've been talking to, this is not anyone's official position or anything. They really do see the kids suffering educationally, especially, but also socially and emotionally. Although some kids are doing better with virtual school. I have to tell you, some kids are doing better. But some parents are taking it to the extreme and they don't even let their child see one single other kid. I think that I would say, in my opinion, that's too strict.
You know, sometimes I see some people, he's the only one in the car, he's driving and he has this mask. I never understand if he's scared of
I know.
I
see that too.
I don't know.
Or they're walking where there's nobody, everyone else is driving, they're the only person, and they have their mask on. But I don't know.
I know.
I'm guilty of that.
Maybe it doesn't
sorry.
bother them. Some people are more scared than others. We've definitely learned that. Okay, so in this program, you can learn the basics, but if you already know the basics, you can learn a lot. I had a guy in, let's see, Adrian Billings. He works out in Presidio, Marfa, and Alpine. And he's like, well, you can help me with my bipolar patients. I have this kid on lithium. And I was like, wow, he's brave. He's a family. I think he's family. And, but there's nobody there to help him. So he just had to figure it out. So he does call me from time to time. And he has residents rotating with him and they call too. So that's another thing. Your residents, your medical students, your nurses, your case managers, anybody who works for you, if you want them to call us, they can. It doesn't have to be you yourself. If it's a medication question, it's better if it's you yourself. If it's you think a kid needs to get in and be seen more quickly, then it's fine if some other person from your clinic calls us. So we really want to meet you where you are. General questions or specific questions. And then people are also starting to give follow-up calls in terms of not us we won't call you, we won't bug you, except to get you to sign up, but and tell you about special events, but we try not to bug you too much. But I'm talking about you calling us on the same patient more than once. So like they come in for their second appointment and they're not doing well, we can help you with that. So it's not like a one-shot deal. You can call us as many times as you want about the same patient, about different patients. And please request topics that your group wants to learn more about. So here we have some more QR codes. This top one is, if you scan this with your phone, you can download the links to all of the CMEs that we are planning. We have all the way through August planned, and then, but give us your, this is a well-funded project, so we can definitely add in extra sessions for any kind of organization. And we've even done things just for one clinic. Like there was one of the kids that killed himself last year was a patient at a clinic at Fort Bliss. And so we did a presentation on how to talk to parents and children about suicide. We did it just for their clinic. So when we started this project, there were only 31 states doing this type of work in the United States. And already, just a year later, there's already 40. So
anyone in the country can log on to our series. We've never even we can have up to 500 people. We've never had 500 people. So we had 161, so we were happy about that. So if you have friends that want to log in for the educational part, they can. We're not allowed to consult. We're not allowed to give advice for patients that are outside of Texas. So, and then this is the National Network of Child Psychiatry Access Programs. So this is a link. If you scan that, that's a link for people in other states to. It basically, you put it. It's an organization that I belong to, and we try to get best practices going and make improvements and share information. And you go to their main website and you type in your state, and it'll tell you exactly who to call. Hopefully, you guys will call us then. This is just an example of our little posters that we put together. Raul. He worked very hard on these, and they always look fantastic. And we have these little QR codes. You just click that so you can watch it on your phone. And so thank you so much for joining us today.
And Dr. Martin,
me.
We did have a question regarding the time. So how fast we get back to the providers that call. And the line is active from 7 a.m. to 4 p.m. Mountain time. But if you call in within 30 minutes, you will get a response from a therapist or a psychiatrist or psychologist, depending on what your requests are.
Yeah, and that's the maximum time. But you know what? We've never taken that long. And usually we can transfer the call immediately because we're not busy yet because it's just started. So right now you call and we'll answer. It might even be me that answers. It's me and it was Dr. DeVargas and I that are the psychiatrists on it. We have our fellows with us, but really this program was the consortium decided we wanted to train the fellows to do it, but only the attendings are actually taking the phone calls. So it's myself and Dr. DeVargas here for this area, and probably you guys all know her too. So please call us, and we pretty much answer the phone right away. And please leave a message if it's after hours, because we always are checking our messages. And it's the same phone number for all of Texas. It's kind of, the hours are a little odd. I don't know. Give us info on what you feel about the hours. They wanted us to be at simultaneous with the rest of Texas. And then our region is partly in mountain time and partly in central time. So that's why it's 8 to 5 was the idea. And we got, over here, we got to wake up earlier, I guess.
Actually, today I was very impressed how fast you respond to me and detailed. It was a great help. And I'm glad to meet Raul Gomez. He sent 10 million of email. I always delete it right now. I will not delete it anymore since I know him.
That's good.
Yeah, every time I open my email, Raul Gomez, and I delete right now. I promise you, I will read it. I will not delete it.
Thank you.
Appreciate it.
Thank you.
And just for everyone to know, if you're interested in receiving CME credit, there's a survey that I shared in the chat. So please just take a minute to complete that. It is a requirement for CME credit, so just keep that in mind.
The survey, you mean, Raul? I'm sorry, I missed that part.
Excuse me?
I missed what you say, the last part.
Oh, it's a survey here in the chat. And yes, Dr. Patak said, can we send in an email? We can definitely do that.
Yes.
Yeah, please. Then we do it. Yeah, it's awesome.
Yeah. And another thing we want to talk about with you all tonight is that it doesn't have to be, when you're signing up for the program, most of the information about your clinic we can get off the internet. We really need a fax number they want us to get a fax number and an email address. But most of the other stuff we can get off, and it doesn't have to be you as the provider that is calling to sign us up. Sign yourself up. You can have, if you have a clinic manager, if you have a nurse, they can just send us a list of names and we'll sign up everybody at the same time. And when you sign up, all you're saying is that you understand how the program works, that it isn't that we are taking direct referrals and seeing the patients ourselves, but that we're helping you manage the patients, but also helping you make decisions does this kid really have to go in the hospital? Do they really need to see a child psychiatrist, sooner or later? That sort of thing. So it can be just an administrative person in your practice that signs you all up. And it's pretty It's pretty simple. And I want to tell you all too about another project that's really taking off. And it is a program through the schools. It's for an assessment and a short treatment through the school systems. Now, not all school districts have signed up yet, but most of the ones in El Paso have signed already. El Paso district has not, which of course is the biggest district. So I hope eventually they'll want to let us help them with any problems that children are having. But so if you have patients that are in other districts like Consortium, Isleta, we have an in-person clinic. The other ones are telemedicine. So we have Consortium, Davis, Tornillo, Socorro, and then even there's a district down in Valverde County, and actually we get most of our referrals from there. They have really taken advantage of this school program. And so then you would get an evaluation by a therapist and a psychiatrist if necessary. So that program are fellows and our residents, and then we have therapists, and then I'm the supervisor for that program. So the way for the parents to access that service is to ask their school counselor.
Dr. Martin, the school districts, they have this contract with out-of-town people after hour or the telemedicine. Do they consult you? Do they know about this program or no? Or they don't consult?
They know about the program, and most of the school districts have signed up. It's the first time hearing that there's an outside agency providing services. I heard a little bit, but I didn't know much about it until I heard you talking about it today.
Yeah.
But yeah, I wish they would. I wish the EPI state. Of course, we're the outsiders down in Valverde County, but there's no psychiatrist there, so it's not like there's no child psychiatrist there, so it's not like we're pushing out the locals because it's either us or nobody. So it's either us or some other big city in Texas, like they have telemedicine from San Antonio or something.
I think this is one of our best mission or important mission to fight this outsourcing from out of town and alienate our pediatrician from taking care of their own patients. It seems
that's no good.
Yeah.
That is no good. Yeah, the clinic at Isleta district is Dr. Handel. He's in here, right?
Yeah, he's here.
Dr. Handel supervises that, and then Dr. DeVargas, and we have our fellows in there, and it's for the psychiatry part. So they get locals at Isleta district, but I'm hoping that more of the districts will sign on. And then it's interesting because even in some of these counties that don't have very many people, they didn't want to sign with us. One county, it was because their school counselor is also an LPC, a licensed professional counselor. But it's not the same as a psychiatrist. So yeah, maybe they don't need she can do all the therapy for that district, but we can help them if there's anyone that needed medication, but I don't know. We'll see. Hopefully more people will take advantage of it. It's just something that the Texas legislature really wanted all Texas kids to have access to, but it has to go through the school board. So not everyone's taking advantage of it, but most of the ones around here. And El Paso, it's going through their levels. It's not that they have said no, it's just going through, they just have more bureaucracy. Of course, they have a different superintendent all of a sudden. Whoops.
Yeah, I know.
So we'll see how that works. Because pretty soon, I hope to say any kid in the public school can get 5 sessions, but not quite yet. Not quite. Now, this bill has also paying for many other things. We're doing a research project with all of Texas on depression and suicide. One half is depression and suicide, and then the other network is trauma, childhood trauma. And so every medical school in the state, they also have a research team that's enrolling patients. And so it's ages 8 to 20 for both the projects. And so if you know anyone that would like to be interviewed for that, there's no intervention. The Texas legislature is very, it's Texas, they're on the conservative side. They don't want us making their kids into guinea pigs and doing experiments on them. So there's no experimenting. No medication, no therapy. It is a series of interviews to follow the course of these kids for an entire year for each child. So, and the patients get paid $300. So you can also call us if anyone wants to sign up for that.
Trauma is like what, Dr. Martin? Can you give us an example? Trauma, I don't understand.
Oh, so the trauma, they're really, it has to be a trauma that would qualify for under the criteria for PTSD. So it would have to be like physical harm, physical child abuse, a sexual assault, but also witnessing those things in others, witnessing a death, witnessing someone else hurting another person. But also like anything that's considered near death too. Like most of the PTSD research in the whole country and probably in the whole world is done on car accidents because that's a very common one. Of course, that's usually a one-time. So this study is really unique because we are enrolling children that are the victims of child abuse, which of course usually goes on for years before anything happens. It's not a one-time thing, hardly ever. So those kids are going to be enrolled in this study too, if they want to be. Only if they want to be. And they'll get paid like $300 over the course of the year. Oh, the age, Dr. Patak's asking the age. It's 8 to 20, so young adults too. 8 to 20. And I've learned a lot about research doing that. It's very complicated.
Thank you very much. Dr. Handel, you want to make some comment or no? I don't know if he's still there, Dr. Handel. Thank you again, everybody. It was great. Dr. Martin, we appreciate this a lot. Thank you for everybody. And guys, have a safe trip and stay safe.